Great. So welcome everyone. Thank you so much for joining us today. My name is Sarah Harlan and I'm the Partnerships Team Lead for the Knowledge Success Project at Johns Hopkins Center for Communication Programs. And Knowledge Success is excited to be partnering with FP 2020 on this webinar series. This is our fourth session in our Connecting Conversation series. And if you missed the first 3 sessions, you can watch the webinar recordings and get up to speed. Those are posted on the FP 2020 YouTube site, and we have also been publishing blog posts on the Knowledge Success site where you can find those links. So we'll get started with introductions and housekeeping while others join us. In the meantime, please write in the chat box who you are and where you're calling from so we can know who's joining us today. This webinar will last for approximately an hour. We'll have some short intros followed by an open question and answer session. And this webinar is being simultaneously interpreted into French, and it's being recorded in both English and French. The webinar recording will be available in the coming days. To listen in French, click on the bottom where you see interpretation, and it will take you to the French channel, and you can then mute the English option. So participants are muted throughout the duration of the session, but if you have questions for the speakers, please type them in the chat box as you follow along, and we'll be collecting them for the question and answer period following the presentation. My Knowledge Success and FP 2020 colleagues will be moderating the chat box, and we'll get to as many questions as time allows. So just a little bit about this Connecting Conversation series in case you missed the last several. Connecting Conversations is a series of discussions on adolescent and youth reproductive health hosted by FP 2020 and Knowledge Success. And over the next year or so, we will be co-hosting these sessions about every 2 weeks on a variety of topics. And this isn't your traditional webinar series. So we're using a more conversational style, encouraging an open dialogue and allowing plenty of time for questions. So we guarantee you'll be coming back for more. This series is divided into 5 modules. Our first module started on July 15th and it's running through September 9th. And this module focuses on a foundational understanding of adolescent development and health. So we are really setting the stage here with this first module and offering a framework for understanding adolescent and youth reproductive health and implementing stronger programs with and for young people. So our topic today is learning from our mistakes. So now I'm pleased to introduce you to our moderator, Emily Sullivan. Emily is the Adolescent and Youth Engagement Manager at FP 2020, and she's a committed youth advocate, and she's going to introduce our speakers and lead our discussion today. So welcome, Emily. I will hand it over to you.
Thank you so much, Sarah. And thank you to everyone coming in from so many wide variety of places: Egypt, Myanmar, Madagascar, Florida. Doesn't get much more diverse than that, which is really excellent. So as Sarah said, I'm Emily Sullivan. I'm from Family Planning 2020 and the Adolescent and Youth Engagement Manager. And so today we have Chandramuli, Sonia Cafe, and bless me, Anjani from Nigeria. Sonia is from PAHO and Chandra's from WHO. So the 4 of us altogether are going to have a conversation today with a topic on learning from our mistakes. And of course, we're a little bit avoiding the word failure there and softening it a bit into the word mistakes. But the main point of today is that we all know that if we don't take the time to really focus on what we aren't doing well, we can't do any better. And I think we all have a friend who might be very boastful, always saying how wonderful they are at certain things, who never acknowledge their failures, and usually that person is quite obnoxious. So we're trying to avoid being those kinds of people and are all here today to learn from one another. And to recognize that if we don't take time out to discuss mistakes, discuss failures, discuss what's not working, we can't possibly move forward in a way that we feel good about and that we know is productive. So with that said, I want to encourage everyone from all over the world who's joined us to really think about 3 things before Chandra kicks us off. The first is that As we said at the end of our last presentation focused on social and cultural norms, that this is a complex issue. Trying to figure out how to best ensure that adolescents and youth don't find themselves experiencing an unintended pregnancy is very complicated. And so to pretend that the solution is anything but complicated would be a bit of a lie, lying to ourselves and lying to our mission. And so the truth is that if we don't recognize the complexity, it'll be hard to move forward. And although today we are focusing on mistakes and failures and how to do better, we have a whole series that's focused on solutions as well. So please don't be frustrated that today is focusing on mistakes and missteps and failures, but please acknowledge it as a space specifically designed to do that because it really is important. So I ask everyone on the line to be very open-minded, to come today with the spirit of trying to improve the way that we do our work. So with that said, I'm going to first ask Chandra to kick us off with a bit of an overview. And after Chandra gives an overview in the next 5 to 7 minutes, then we're going to dive into a discussion, and I encourage you to submit questions into the chat box, which we will be following along very closely to include your questions. So go ahead, Chandra, why don't you go and kick us off into this discussion on learning from our mistakes.
Many thanks, Emily, and greetings from the World Health Organization's Department of Sexual and Reproductive Health and Research. My grateful thanks to the organizers, FP 2020 and Knowledge Success. The next slide, please. Last year in 2019, the world commemorated the 25th anniversary of the International Conference on Population and Development. Working together with UNFPA, we brought together a range of stakeholders from around the world, including 7 young people, to draw out the lessons learned over the last 25 years. As you can imagine, we identified things that were done well and things that were done not so well, missteps, mistakes, and even some failures. That's the focus of my presentation today. I want to stress that I make this short presentation with respect. This is not about blaming and shaming. This is not about finger pointing. It is to acknowledge, as Emily said, that we all make mistakes and need to do a better job of trying to avoid avoidable mistakes and learning from all kinds of mistakes. The next slide, please. So in this presentation, I'm going to talk about 5 mistakes. 1, one size fits all. Although there's widespread recognition that adolescents are a heterogeneous group, most programs still use a one size fits all approach. Most, not all. We must use a tailored approach to respond to the different needs and preferences of different groups of adolescents, older and younger ones, married and unmarried ones, male and female ones, those who are parents and those who are not. Projects, NGO projects tend to do that, but large-scale government programs generally don't. But they're beginning to change. Here's an extremely good example of Sierra Leone's initiative to respond to first-time mothers as part of a national program. The next slide, please. The second point is poor reach. Many adolescents are not reached by the interventions that are intended for them. What this means is that even though the interventions are in place, they're not being reached. As can be illustrated, as is illustrated by this evaluation in India. 5 years into the project, an evaluation discovered that many important groups were not being reached. What are the implications of this? We must assess who we are reaching and who we are not with our interventions and adapt our delivery strategies as needed. And we can do this with coverage studies. And these are studies that are easy to do and are extremely useful because they'll point to those who are being left behind, an important focus in the context of the Sustainable Development Goals. The third point. The next slide, please. Inadequate fidelity. Now, interventions that have been shown to be effective in research studies, in projects, generally tend to be delivered inexactly and incorrectly. In other words, with inadequate fidelity. So it's not at all surprising that they are not effective. What we absolutely need to do is to ensure that a proven package of interventions is delivered as is, and each intervention is delivered faithfully. Let's take the example of comprehensive sexuality education. We know from the International Technical Guidance on Sexuality Education that it's extremely important to deliver sexuality education and link it up to services, link it up to health services in the school or linked to the school. This doesn't happen in so many places. And as we know from many, many studies, as this UNESCO policy brief points to, the content and the delivery of sexuality education leaves much to be desired in many, many places. So inadequate fidelity. Interventions which are effective in the laboratory are delivered extremely poorly in the field. The fourth point, please. Low dosage. Now, dosage is important. We've talked about tailoring it to different groups of adolescents. We've talked about reaching adolescents. We've talked about fidelity. One very important point is dosage. Interventions are delivered with low dosage, for example, using only one channel or only 1 or 2 sessions. And then it's not at all surprising. I mean, the last session was about social norms. Rebecca Lundgren stressed that social norms are deeply ingrained and we can't change them very easily. It takes time and effort to change them. So interventions to improve knowledge, attitudes, beliefs, and behaviors should be delivered with intensity and sustained over time. This wonderful review by Gage points to the fact that for girls' clubs and life skills programs, they were much more likely to be impactful when they ran over a long period and when girls attended regularly. Initiatives which did everything they could to get the girls to come back were much more likely to show results. And again, that's not surprising, but it's not always done. The fifth and last mistake that I'm flagging in this presentation. Next slide, please. Sorry, this is a crowded slide, but the main points are on the left. Inappropriate use of training, overuse of training. We all recognize that a competent, caring, compassionate health worker is crucial to an adolescent responsive health system. We recognize that, we know that. And so that translates into training. Training, 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 and training. In many places, training is the only approach used to improve health workers' competencies, attitudes, and motivation. And what is worse is that it is often done very badly. In order to save time, training is shortened, all the participatory activities are thrown out, and then what you have is a flood of PowerPoint slides. We have to do better, because this is a very crucial part. And although I'm talking about training health workers, this applies to teachers as well, and all other adults who work, and young people who work with young people. So we must implement a package of proven approaches to build abilities, to motivate, and to enable health workers, teachers, and others to do their best. On this slide, you will see the categories of interventions to build abilities, to motivate, and to enable. Increasingly, what we are learning is you need to bring teachers and health workers together to learn from each other, support each other, and overcome biases. Much more that they learn from each other than having experts. It's not either or. Experts have a role to play, but we need to use a package of approaches. That brings me to the end of my list of 5 mistakes. To wrap up, I'd like to go to the next slide, please. One of our big failures, if you like, is this deathly silence about failures, about mistakes and failures. I received, red lines in my report card in school. Perhaps some of you did, perhaps some of you didn't. But I remember how difficult it was to take that report card to my parents. And essentially, you try to hide the report card for as long as you can till the day before you have to hand it into the school. And that's really what we do in public health and everything else. We must minimize avoidable mistakes and failures, mitigate unavoidable ones, and accept that innovation and risk taking go hand in hand. And most importantly, we need to learn from our mistakes and failures, our mistakes and those of others, just like we learn from successes. My next and last slide. This is a wonderful spectrum put together by Clea McNeely from the Gates Foundation, and it has 4 points that I'd like to flag. She describes mistakes as preventable, unavoidable, and intelligent. So preventable mistakes are failures in routine or predictable operations. You know, not doing a situation analysis before designing. That's a preventable mistake. Unavoidable is complexity, uncertainty. There is a coup in the country. And what do you do in this situation? There's a flood. What do you do in this situation? And there are intelligent mistakes. For example, we know that we are trying to find ways to reach young people with SRH services in the context of COVID-19. And we need to understand that in trying to do this, we'll make mistakes. So what do? You avoid preventable mistakes with the actions listed there, unavoidable mistakes with the actions listed there, and intelligent mistakes with the actions listed there, which is very much about linking up risk-taking with learning and embracing risk and celebrating risk and celebrating failure. And to conclude, we must learn. We must learn from whatever mistakes we make, preventable mistakes, unavoidable mistakes, and intelligent mistakes, because only when you do that, you can become better. Thank you, and over to you, Emily. This presentation and the papers that I've drawn the points from will be available through Knowledge Success. Thank you, and over to you, Emily.
That was great, Chandra. Really gave us a good overview of everything we're hoping to at least touch upon today. There's a lot there, but I think that what we can all agree on is that the only real failure is failing to acknowledge our mistakes and failing to do our best to learn from them and improve. And so Chandra covered all kinds of things. He covered, you know, a combination of moving forward with a one-size-fits-all approach, assuming that all young people are going to be solved by any single solution, that we have poor reach, we're not reaching the right young people that we're intended to. Inadequate fidelity, meaning not following the guidelines and the evidence as closely as we should. Low dosage, not you know, doing the kinds of programs that we're doing with the right intensity. And we're heavily focusing on things like training and one-off trainings. So I'd be curious, Sonia, in your experience in the LAC region and the Latin Americas and in the Caribbean, what would you say are sort of your reflections on some of the things that Chandra has shared? And then we'll come to you, bless me.
Thank you so much. Good morning and good afternoon, everybody. It's wonderful to be here. Greetings from Paho. This is such an important topic, and I'm really grateful to be part of this conversation because in our region, we have seen that as well, the importance of benefiting, learning from mistakes and to try to improve as we move along. I think that there are a few reasons maybe that I have seen working with our wonderful counterparts in the LAC region, why people are hesitant maybe to acknowledge mistakes and to bring them out now in the open. One is that I think for the longest time, adolescent health has been almost an activism issue. People put their heart and soul into defending the importance of working with adolescents and for adolescents, which is still very valid, and in developing interventions. And then it's very difficult when your heart and soul is in it to maybe admit that, hey, maybe this is not working. It might feel good, but it's not generating results. And so that's one of the things we still need to do activism for adolescent health, because sometimes it's still the stepchild. But at the same time, there's a lot of new evidence, very solid evidence on what works and what does not work. And it's a hard decision to say, hey, maybe we need to stop this and do something else. I think that's one reason. And then the other reason that I would like to quickly mention might have to do with donors, with funding, being afraid to admit failure or mistakes out of fear that you will lose your funding. And again, that is something, once we have guaranteed funding, or we have greater access to funding, and we all realize that learning from mistakes is growth, then maybe that will open up the space to strengthen monitoring and evaluation, and to make sure that we learn from our mistakes and that we improve as we go along.
That's really two really excellent points, Sonia. As I'm sure Bless Me knows something about the blood, sweat, and tears that goes into that activism, and then feeling a bit frustrated on the other side when these things you've been advocating for and pushing for come to fruition, but the outcomes are just not there, and you get a bit. It feels quite badly to then reflect on, why isn't this working? What have we done wrong, despite all of this really hard effort in getting others to recognize the needs of adolescents. So I don't know, Bless Me, if you have any reactions to some of the things that Sonia or Chandra have mentioned so far.
Yeah, thanks, Emily. Yeah, I'm sure everyone can hear me.
Yes.
And the echo is not so bad. Yeah, thanks, Chandra, and for the presentation. And I'm really happy and glad to be part of this conversation, helping us to reflect on some of the interventions we are doing across regions and see where to tweak and where to either change the course of what we're doing and all of that. So yeah, just to make some few comments on Chandra's presentation, I think looking at the evidence that has been said before us, it is very evident that we seriously need to do things differently. So the first comment I would like to make is on trainings. Yeah, so one thing I want the community of practice to realize is the fact that, yes, whilst we so much focus on when we talk about adolescent health, adolescent sexual and reproductive health, I think we've not really gotten the issue right with the providers or with the health workers in this case. The issue is a behavioral issue. And I think we need to start looking at changing our trainings in such a way that it addresses behavior rather than addressing their technical skills. Health providers, I believe they went to school, like they obtained this technical knowledge and technical skills from schools, but basic things that we need to now start changing the course of our trainings or the course of how we engage with providers to address most of their behaviors, which has to do with judgmental, which has to do with how they respond to adolescents. And that's when we can now have a responsive adolescent health system. Because really, it's not just about the sexual and reproductive health of young people. It's also about when they go to the facility for things as small as malaria. Well, malaria is kind of common in Nigeria, so it's like the easiest example to point. You know, it's as simple as when I go to the hospital and I have malaria, and then the healthcare worker attends to me in a very responsive and very friendly way. So what is the real issue is one thing we need to start focusing on is how we need to change the curriculum or the content of our training to address behavior and change their behavior, just the way we are looking at changing the behavior of young people themselves to be able to pick positive health attitude. Same thing, we need to start looking at our providers that same way. Then talking about dosage, I think it's important that we also look at how our interventions, while I understand that donors are the ones, and hopefully donors are also part of this conversation, is the fact that when we test an idea in some part of the country or some part of a region, and then we automatically expect the national statistics to change without scaling it up to other areas, things will still keep not working. We can't expect to do, for instance, in Nigeria, we can't expect to test an idea in about 3 local governments out of 20 local governments in Lagos State, Nigeria, and expect that the national statistics about teenage pregnancy will just change all of a sudden. So we need to look at the duration of years that we are testing these ideas. And we need to scale up to other areas so that, yes, we can have an all-round intervention, and then we can now see the changes that we really want to see. We really need to start looking at that. How can we scale up this proven to work models? As Chandra has said earlier. Thank you very much, Emily. Let me not take all of the time. So much to say.
Exactly. There is so much to say. We're already getting 2 questions in the chat box. But I think we should just take a moment to dive a little bit more into the trainings piece, because it is one of the more common interventions now, is to do, unfortunately, often one-off trainings or trainings that have limited follow-up. I don't know if Chandra or Sonia, if you wanted to react to some of the things Bless Me was saying about trainings. We seem to be stuck in a cycle of training after training. What really are the results that we're seeing, and why would you say they aren't often what we anticipate or hope for?
Sonia, do you want to go first, please?
Sure, thank you, Chandra. I think part of the reason why we are in this situation is because of habit. No, the modalities that we know, those are the first ones we grab to. Is like when we think of training, is making sure we cover all the materials. We have all these topics. We have 10 modules to cover, and not understanding how learning really works. I'm just thinking of some recent examples in our region when we started talking about what is adult learning, and once we want to increase certain competencies in our health workers to improve the quality of health services for adolescents, thinking about it in a different way, to say, hey, every adult comes to the table, and definitely every health worker comes to the table with some knowledge, with some experience. How can we maximize that? How do we change it around? I think what Chandra said is so true about allowing people to learn from each other, because standing in front of a room, and this is how many of us, at least people from my age, how we learned in school. The teacher stands there and the teacher will teach you. So it's really that top-down model that we are used to, and that maybe instinctively we replicate when we need to train. But having this horizontal learning and saying what is most important for us and how can we learn from experience, I think that's a totally different approach. Maybe we can use the word a totally different paradigm of training. And I know there are good examples of that. And so those are the ones we need to adopt more and professionalize and change the way we look at training. And I think these types of conversations help for us to think differently about training of health workers.
Can I pick up on that, Emily?
Excellent. Yes, please.
So I'd like to pick up on both what Bless Me said and Sonia said. Bless Me talked about changing the nature of training. And Sonia rightly said we have to go away from the habit of what we used to do in the past and look for new ways, new paradigms for adult learning. So I'd like to make 3 points. And the first one is, like Sonia said, we do training just because it's been done. When we talk about improving health worker performance, we just say trained health worker. It's almost used interchangeably. So training is not bad. You know, in fact, training is important. But we know from reviews that training is best when it is done with small groups, when it has focused topics, when it uses multiple methods. So training must be done well, and it must be combined with other interventions. So that's the first point. If we do training, then as Bless Me said, we need to do it well, carefully matched to competencies that we are trying to improve. The second point is, in addition to training, there are a number of effective, proven approaches. For instance, to improve performance of health, competence of health workers, you can do training, you can do retraining, but you can also give people desk reference tools for them to refresh themselves. Then another huge issue is motivation. Again, as Bless Me said, They may know exactly what to do, and but they may not do it because they may think that giving contraception to an unmarried adolescent is wrong, or homosexuality is wrong. And so those are issues that cannot be addressed by training. If somebody comes from Geneva, or somebody comes from the capital city, health workers will keep quiet and listen and nod and continue to do what they have to do. What you want to do is to challenge them and change some of these issues. And that's where this collaborative learning approach is crucial, where people can learn from each other and can be challenged. And the third and last point, which I didn't touch on earlier, is accountability. Many studies have shown that health workers know exactly what to do, but when a dummy patient is sent in, a mystery client is sent in, the scores that they scored in the presence of an evaluator dropped from 80 to 20. That means they knew exactly what to do, but they didn't care about doing it because of impunity. And for that, you need accountability. You need community accountability, and you need adolescent accountability. And with this big move to universal health coverage, where we're talking about responsive health systems, where communities are accountable and young people are accountable, we need to hold health workers to account. After all, they're carrying out a function for which they are paid and supported, and they have to deliver. And if they don't, they need to be held accountable. It doesn't mean punishing them and putting them in jail. It just means that somebody is watching and somebody can hold you accountable for your performance. If you treat an adolescent with disrespect, you are held accountable. If you withhold treatment because you believe unmarried adolescents shouldn't have sex, you're held accountable. Over to you, Emily.
There's a lot to dive into here. I don't know, Blessme, did you want to say anything regarding training, or should I move on to the next question? We've got a lot of hot ones in the chat box.
I think we said so much about training. Maybe we should just move on to the questions and chat. Very interesting conversation.
Great. So Chandra mentioned two things that I think are important for us to touch on next, which are related to questions in the chat box. You mentioned accountability, and accountability, in this case, you were referring to providers, but someone in the chat box was asking about what are some of the ways we can encourage whether governments, NGOs, donors to take a look at those red marks and really make an actual change when they go to review what's really happening. What are some advice that we all may have about how to encourage some of those, whether in this case they were referring to governments to really take a closer look at their initiatives that they're proposing and their policies and programs, and really do a hard look to see what are their marks, how well is this really working? What advice do you all have?
Again, I'm going to defer to Sonia to start. As a regional advisor, she's very close to what's happening in countries, and I can build on what she says.
Excellent.
Right. Thank you. Yes, I think that, and again, from what some of the things that we have seen, that we have been understanding from what's happening in the field, is that, first of all, it's important for governments to acknowledge competencies and efforts of health workers to be trained and to improve their performance. Just as an example, for several years in our region, we ran a scholarship program for training in adolescent health. And once, after a few years when we did an evaluation, what several people said was, I didn't get the opportunity to put into practice what I learned. And there was no incentive because I did not advance in my career. I didn't get, and it is not always about money. It's about recognition, acknowledgement, advancement, appreciation. And so I think that it's very important to encourage governments to have this continuing dialogue with health workers. What are the incentives that will help them and motivate them to keep moving forward and to keep trying to do better, to improve their quality. In one of the countries, there is a department that looks at quality control, because I really like what Chandra said about accountability. And what they have is that they challenge their districts to submit their quality improvement plans and results. And every year they have a meeting and they recognize some of the efforts. They call them to the front and they get a plaque. And there's a publication from the government every year that documents some of the best practices. That's a way to keep motivating and pushing the continuous improvement of quality. So those are there are some practices, because I know people say poor pay, poor conditions. Yes, those are limitations, but there are things that we can do and that governments can do and that local governments also can do to keep pushing the envelope and keep encouraging and challenging improvement of the quality of services.
Good. And I've also heard of some, not governments, but organizations issuing awards for actually the biggest failure and acknowledgement of failure, which I think is also a very interesting approach of recognizing those who are willing to come forward and say, we also tried this and it didn't work, and this is what we learned. Mm-hmm. So yeah, so I don't know, Chandra, would you like to go next, and then bless me on
what Sonia said? You know, and your question was, what can we do? I mean, there are a number of activities you can do at the community level. For example, a community audit. CARE International has this community scorecards, which they use. They're monitoring citizens' charters, public hearings. You know, there is a when a death occurs in the hospital, there's a death audit. So there are things you can do at the local level, and increasingly in the context of social accountability, this is happening. But what can you do at the national level? And I'll give you one concrete example. In 2014, the government of India launched this new Adolescent health program, in Hindi, RKSK. A big program, largely funded with Indian resources. A multifaceted program to address a range of issues. 2 years into the program, the government recognized that it was not moving as well as they had hoped it would. The government worked with us, invited WHO to support a program review. We worked with researchers in India to do a review in 4 states, as well as at the national level. We presented the findings in a Ministry of Health meeting that the Ministry of Health and WHO convened with about 50 people there. I was extremely nervous going into the meeting to see whether they would be receptive to the critical feedback that we had. And I must say, I was proud that they acknowledged the comments from the senior level all the way, to accept the comments, accept the criticism, the constructive criticism and respectful criticism, but they accepted it and recognized that they needed to do better. But I think they did that because there were clear messages from the Prime Minister that he wanted the program to function. So there was a commitment to improve. So I think if there is willingness to improve and a safe environment to talk about failures and mistakes, that's very nice. Now we talk about governments, but what about us? I've been in WHO for 25 years. I've worked in a number of departments. In some departments, I would have never talked about any mistake I made or failure I had, because I did not believe, did not have faith that this information would not be used against me. In other departments, I felt safe to talk about failures. And I think people will talk about failures when it's safe for them to do so. And that's the big challenge. And that's the point you made, Emily. We need to create a way. We don't want to celebrate, avoidable failures. We don't want to celebrate the fact that somebody has not done a situation analysis and designed a program which fell on its face. They have to be held accountable for that. But if somebody makes a mistake, despite doing the best they can, that must be celebrated. Over to you.
That's great. So we've talked about some of the ways is to think about an award program appropriately, not to just those, not adhering to what's already known, but also local scorecard interventions, really looking at conducting research that the government agrees to really look into some of those projects, review that research collectively and strategize together. Bless me, is there anything that you would like to add about how to really work collaboratively with governments in particular about showing those marks and doing something differently?
Yeah, so I really think that just riding on what Sonja had said, I think it's important for our health workers that the government does something that has to motivate them. It might not necessarily be money. And I think another major issue is the fact that an health worker does so many things. So sometimes when I go to the closest facility to my house, I pity the provider in the facility. So one of the things that the government also needs to start looking at is increase the number of health workers available to attend to clients in the facilities. And also, the award system is really, really key and important. Also, they need to see how, if I as a health worker, I attend a training and all of that, there needs to be a way that it reflects in the way I'm advancing in my career path. Because providers will just keep getting tired of trainings without any advancement in their career or without getting promotions. So those are the other things that the government might need to look at and look at, oh, how can we design our promotion system based on the performance of this provider and based on the competence of the provider in terms of adolescent sexual and reproductive health now. And also align their interventions, align their interventions in such a way that a partner supporting the government is not training the same set of workers, another partner come and train the same set of other workers. I think that coordination also needs to really be strengthened at the level of the government so that we can maximize the resources that we have and ensure that everybody is happy. The government is happy, young persons are happy, the workers, the health workers are happy to do their job. And then, of course, we can now start seeing the changes that we really want to see.
Emily, a quick comment to build on what Bless Me said. She started by saying she felt sorry for some of the health workers. And, we have talked about holding them accountable. But at the same time, one of the things that our Director General Tedros continues to say is that we have to celebrate their work. We have to pay them their salaries on time. We have to make sure that they see fairness and not injustice in promotions. And we have to give them, protective equipment. We've seen even in some of the richest countries of the world, they don't get the supplies that they need to be safe and to provide good quality care. So, before we hold health workers and teachers accountable for performance, we also have to hold governments accountable for protecting health workers and supporting them to do what they need to do. So it's a chain of accountability, accountability at a number of different levels for a complementary set of functions. That only can ensure that, when a 16-year-old girl goes and says, I think I missed my period, can you help me? She gets respectful treatment, correct treatment with confidentiality and privacy.
That's great. Someone in the chat box is agreeing with you, Chandra, reference, and all of you actually, saying that, yes, healthcare workers are treated unfairly based on the same gender issues that the rest of the world in different communities face, as well as lack of decent pay, work conditions, and that these are genuine challenges to then add on top of that, compassionate care towards adolescents, which might not necessarily be their top priority, can be really difficult. So I want to move on to another question. In Chandra's opening presentation, he referenced a lot about duration, dose, intensity, meaning essentially a lot of the programs and interventions that we've all been focusing on for adolescents and youth, trying to eliminate or decrease unintended pregnancy among adolescents, really rarely has the kind of length or fidelity, meaning the adherence to evidence that we would hope that it would. A lot of these things are mandated by donors. The length of a project, how they're designed becomes a bit of a donor requirements, but also how NGOs are structuring them. What are some of the things we can overcome this really monster of an issue of you know, of low dose, low duration. How do we combat this giant challenge? Any thoughts? Who would like to go first? Go for it, Sonia.
Yes, thank you.
You can see I follow in her footsteps very well.
We have a nice dynamic. So I'll use the example of a program we're implementing here in our region. It's called the Familias Fuertes program that reaches more than 200,000 families a year in several countries. And after several years of implementation, it's an evidence-based program. We noticed that, you know, we were a little bit, let's say, slacking. People were changing the program, saying, oh, you know, it's a program of 7 sessions. Parents don't want to come 7 times. Adolescents get bored. I'm gonna change this and add that. And so what we realized was that we had to go back to the basics and emphasize in the introduction, the organization, the training, the capacity building, emphasize some of the core principles. One, the core principle of fidelity, that once you change a program drastically, and I have seen that there have been some questions about what's the difference between fidelity and adapting to the local situation or the local context. You don't change, you have to recognize what are the core elements of an intervention, and you don't change that. The adaptation has to be with the things around that, but once you change the core elements, core components, core principles of a program, it's not the same program. And so we realized that we had to develop additional tools and additional capacity building modalities to re-emphasize the importance of saying, hey, this intervention has 7 sessions. If you do only 4, you will not achieve the results that are anticipated with this type of intervention based on the evidence, based on the evaluations. You cannot change things without having a due process. And so it was really practical, going back to our implementers in the countries, developing additional materials, and they introduced those materials into their annual meetings and annual training moments with their facilitators and their implementers to improve the quality of the implementation of this program. And I think that those types of things are very important. Again, learning from mistakes, learning from, hey, if we don't do this well, we will not get the results. And that has direct implications perhaps for the funding, for the credibility of the program. And so those are some of the things that we are trying to do to always challenge ourselves and say, hey, how can we do better? The way we kickstarted that process was through an external evaluation to say, hey, bring in a university to do that evaluation and tell us what can we do better. And again, I think that is an example of learning from mistakes.
Thank you, Sonia. Just to build on that, I mean, so like Sonia said, the focus has to be on implementation, and the focus has to be on measurement. And you know, this week, WHO and the world is celebrating the end of polio in Africa. And that's a huge achievement, given that in Nigeria, the last cases were in the conflict-ridden areas affected by Boko Haram. Health workers reached there and provided this focus. So, you know, there was very good monitoring, huge focus on implementation, and that gets the job done. The pharmaceutical industry, the vaccination community talk about the last mile focus. And really, that's what we need to do. We've talked about in the adolescent health field, I think we are now ready to, of course, concepts are important and theory is important, but I think now what we really need is a huge focus on learning from the private sector, learning from the pharmaceutical field to focus on good quality management, and using data to improve performance. So I think that should be the focus. And again, COVID-19 has shown that you don't need a lot of money to do that. Even low-income countries like Rwanda, like Vietnam, middle-income country, have shown what is possible to do. You don't need to be rich to do management of programs very well. I just want to acknowledge before I hand over to you that a number of the comments I made without seeing the chat box were made by Jill on health workers. I fully echo Jill's comments on that. We need to empathize with health workers. We need to recognize that many female health workers are sexually harassed, and you can't. It's very hard to expect them to be kind and respectful when they themselves are being treated so badly. Over to you.
It's an important point, Chandra. In reference to something that Sonia mentioned, Sonia, you emphasized that when trying to look at the way that we can improve programs, it's important to look at the core elements when adapting them. That yes, local adaptation to projects to make sure that the duration is adequate, that the dose is adequate, that the fidelity to evidence is appropriate, that yes, you can change some elements of it, but you can't change some core elements. Otherwise, you can't anticipate that this is actually going to have an impact. I know, bless me, you've had quite a bit of experience trying to implement different projects focusing on adolescents and especially young girls. Do you have anything to add about the issues related to duration and dose and fidelity to evidence when trying to focus on projects, especially those for adolescent girls?
Thanks, Emily. So I'm just going to ride on what Sonja and Chandra have said. I think one of the things we need to open our eyes to, based on the discussion that is happening today, is opportunity for collaboration. It is important that we understand that, yes, while most of our projects focused on target audience, young persons, one thing I want us to realize and get from this meeting is the fact that young people don't exist in isolation. Young people don't exist on their own. They have a variety of environment they exist, and a lot of things influence their health behavior, whether we want to agree or not. And that's what will now bring me to addressing the issue of peer education. I think by now, one thing we should be looking at is collaboration. It's one thing for you to say, I saw a question in the chat box that talked about, peer education is not effective. As someone that has implemented peer education on a very large scale in Nigeria and also on a very community-based scale, one of the things I realized that, yes, while peer education is fantastic, it improves the attitude of the peer educators. In fact, it improves the knowledge of the young persons. One of the things that we are not bringing on board is the fact that we are not putting in place the social environment to help these young persons change behavior. So while they know in their head, or while they have it in their head that, yes, this is the right thing to do, but they don't have the conducive environment to do those right things. So for instance, we have a peer education program, they attend the 7 sessions or implement the content of the project. But yeah, this young person is pregnant. What she needs is a social support so that she will not get pregnant again and support a teenage process. But yes, most times we just do peer education in silos and then we leave that social support. And I think that's one of the things we should be learning from. It's why peer education in itself is great. We need to understand that for these people to be able to change knowledge, to be able to change, we need to bring together services, we need to bring it to perspective, service provision, and all that social support that will enable them to eventually change this behavior. So that's one of the things I'm going to add about duration and intensity. We do projects or implement projects in silos where we are not looking at, okay, when I tell them about this, what next are they going to, what's the next thing? How do I help them access, for instance, a young girl comes and says, I have a problem with my menstruation, then you cancel her. Then what next? Where does she get the drug to be able to regulate her menstruation? Who pays for that?
Right.
Or I don't have money to get sanitary pad. my menstruation is not hygienic. Oh, you address the infections that happened from that. But what happened next? How does she start using sanitary pads? You know, those are the social supports that we also need to look at and bring together to be able to design an effective interventions to young persons. Young persons don't exist on their own. Sometimes they don't make some of these decisions by themselves. And also, we need to be intentional about looking at the people that surround the young persons. While we program for adolescents as a target audience, we need to see how to help the parents also understand the new realities of this adolescent. Yeah, so when an adolescent attends the 7 sessions and then she goes home, it's a different ballgame to implement what she has learned, because the environment in the house or within our guardian, with a guardian, as the case may be, is not so hard for her to change. We will keep the same thing. That yes, this, but I think our interventions are really reaching the right audience and not just reaching them, they are changing behavior from these interventions. Thank you, Emily.
Thanks, Basmi. There was a lot there, but I think one of the main points you were making is about implementing in piecemeal, in small segments. We're expecting that just training or just peer education or just one piece of this to solve an issue. And what we know is that things need to work collaboratively. And I know, Chandra, the paper that you wrote around what doesn't work, along with Caitlin and Sylvia Wong, set small fires all over the world of people panicking about what they were or weren't doing. Yeah. And I, of course, invite Sonia and Blessme to comment this on as well. But I sense that if we don't address or clarify a bit of what the evidence is saying around peer education, there'll be some disappointed people on the line. So would you mind clarifying?
No, I'd be happy to talk about that. But before that, I want to reinforce what Blessme said. You know, yes, we need the safe and supportive environment. You know, the analogy I take is, what does a 9-year-old girl need to cross the road every day to go to school? She needs information and skills on when to cross, when not to cross, what to look for, information and skills. She needs a safe and supportive environment, drivers who respect rules, pedestrian crossings, lights that work, and where they don't work, like in many places, including in India, then you need an adult to help her cross the road. And she needs health services if she's stuck and gets hurt. So it's a package of interventions, not one thing on its own, which is the key point Blessme was making. Another point in the chat, Emily, was, what about by fidelity? Are we saying that you shouldn't adapt it for the local perspective? No, no, no. You know, you can't take a package from Australia or from the US or from England or even from another low and middle income country and put it in your context. You have to test it out. But once you've tested it out and showed it's feasible, it's acceptable, and it's effective, then you have to get a fix on it. You can't keep changing it every day. And that's the point. It doesn't mean that you take something and you photocopy it and you apply it all over the world. Let me come to peer education now. Now, peer education is often used because there's clear recognition that young people talk to each other, that young people turn to each other for cues, for information. When I was a young person and I wanted condoms before, I reached out to other young people to say where to go. So of course, there are very good reasons that peers support each other. And people recognize that, we need to reach young people. So around the world, an enormous amount of money and resources are spent on peer education. That means getting one young person to educate other young people of the same age. The evidence, again, I'm starting with the wonderful point that Sonia started, activism and then evidence of effectiveness. The evidence of effectiveness is that peer education programs, when well designed and well conducted, can improve knowledge in a certain number of initiatives, can contribute to improving attitudes, but by themselves don't lead to changes in behavior. Is that a problem? I don't think that's a problem in itself, as long as we acknowledge what it can do. And we don't study many other things that peer education can do, which is create a sense of community, create empathy, create ownership, create a sense of commitment to a purpose. There are many other things which are rarely evaluated. We've just published a paper with Kat Watson, one of the big champions in peer education, who also had to acknowledge that, clearly what we have is know that it improves knowledge to some extent, to improve attitudes, relatively less evidence on changes in behavior. But I don't think that means we should stop doing peer education. I think we should do it well, and we need to combine it with other interventions and recognize its limitations. And we need to also draw out the many other strengths that peer education can provide. And just to conclude, in the Journal of Adolescent Health, we've included an initiative called Zwandiri from Zimbabwe, where young people with HIV have played a central role working with adults to reach out to other young people with HIV like themselves, to bring them into health facilities for testing and support them to continue with antiretroviral treatment. They didn't call it peer education. There may have been a small amount of peer education as part of that, but it is much more about peer support, about friendship networks. And that's a big strength that we have to tap into. Over to you, Emily.
That's excellent. I think, Bless Me mentioned that in her experience that peer educators themselves have increased knowledge, themselves have had positive experiences with supporting other young people that they have worked with. As Chandra just mentioned, Kate Lane has referenced in a chat box that there is importance to valuing and measuring these highly positive effects as young people, as peer educators. But as I know I've heard Sonia mention before, we can't expect this piecemeal intervention of just peer educators, which is often conducted in a particularly rigorous way, to have outcomes related to behavior change and large-scale change. It wouldn't be fair to rest the future of ensuring that young people can access contraceptive services or make decisions about their fertility or any other decisions simply on peer education, which is unfortunately, I think, what a lot of initiatives do focus
Kate
on.
and I are co-authors of the paper, and while we point to what the evidence says, we are also at the same time the biggest champions for meaningful adolescent engagement in design, in implementation, in evaluation, and in accountability. So, but I think, if we care for young people, we also need to point to where the evidence is weak.
Exactly.
It doesn't mean that we are anti-young people when we point to such evidence.
Exactly. And there was a comment, I know we're over time. So as the Adolescent and Youth Engagement Manager for FP 2020, I know Bless Muse, the youth focal point in Nigeria, someone asked, when do we bring young people into the conversation? When do we start collaborating with them? To me, this is a very interesting question, mostly because the answer should usually be at the beginning. Wherever the beginning is, in conceptualizing what even the challenges are before you even identify what the challenge is when you should be working with young people. Absolutely. Oftentimes their priorities are different than others.
I can proudly say that in any substantive piece of work we do in WHO, we engage young people with 4 criteria. We select them objectively, we support them to make their contributions, we acknowledge their contributions, and we pay them for their participation. The Journal of Adolescent Health paper 4 is led by Marina Plessens, who's 27 years old. She was the lead author of a paper which had World Bank and Gates Foundation and WHO and UNFPA as co-authors. That's the way to do it. I think we have to do it in a way that draws out from young people. That doesn't mean they've got everything right, just like adults don't have everything right.
Sure. I don't know, Bless Me, did you want to say anything on that before we wrap up?
Yes, so I'm just going to make my comment and then just wrap up from here. So yes, I think it's important people, I know the whole world is trying to learn how to work with young persons based on their diversity and all of that. But yeah, I think the point where we need to start involving young persons is at the point of writing our proposals for intervention, is at the point of making policies, because now you want to design a proposal to the donors. You are putting in what you think adolescents and young people need. And then you now, the proposal has been written, has been granted, you now come back and now want to say, yes, if we want to implement this, what do you want to bring about? But I think it's going to enrich our proposal and enrich the sustainability of our project if we start bringing young persons' input at the proposal level, you know, or at the design, at the concept design level, yeah, at the concept design level. And secondly, another thing I would quickly like to touch on is sustainability of our project. I think somebody said in the chat box about how do we work with government? Yes, I think one of the things we are also not seeing is the fact that we need to start aligning our implementations and our projects with the policies of the government on reaching young persons, so that most of these projects can be sustained by the government after the year, the duration of the project's lifespan. So just those two things, young persons should be part of development of these policies in the first place. And when implementing partners or governments are designing interventions to address those policy areas, it is important that they bring young persons' contribution at the concept design level. Thank you. That's the beginning.
Wow, we have really covered so many things. I anticipate that everybody's mind is a little bit like, where do we begin? But the good news is that we'll be following up with some articles that sorry, I'm not supposed to say Dr. Reed, we're keeping it casual, that Chandra has authored, that Sonia has authored, that Caitlin has authored, also some articles that Bless Me and I with other youth focal points have put together over the years on these topics of really looking at what does work, where the evidence leads. So if you're feeling a little bit overwhelmed at this point by the conversation we've had, I would encourage you to look at some of the research and some of the reports we'll be following up with, as well as joining all of our future Connecting Conversations discussions, because we'll be diving into the services aspect, into the youth engagement aspects, into some of the how to scale things like comprehensive sexuality education. So we just want to encourage you that if you're feeling a little bit overwhelmed at the moment, look out for that research, look out for other follow-up discussions.
And please write, we'll respond to every email we get. Okay,
that's a commitment. I don't know if Sonia or Bless Me or Chandra, do you have any closing remarks, perhaps some encouragement around how to encourage others to embrace some of these mistakes and failures in particular, or other comments?
I think you've done a great job. I'm going to let Sonia have the last word.
Thank you so much, Chandra. Thank you. No, this has been very interesting. I also learned a lot. I just want to reiterate what we said at the beginning, that mistakes transform. They might be painful, but when we transform them into lessons learned, then what we're doing is we're strengthening the adolescent health field. We are consolidating the case we have been making for investment in adolescents, and that's all we want, right? And so I think this is such an important point to keep contemplating how we can really celebrate lessons learned, quote unquote mistakes, because that's how we will move forward. Thank you very much for including me.
Excellent. Thank you very much, Sonia, for those comments. I wanted to acknowledge a colleague at, I believe, the Packwood Foundation in India has written some articles about why we need to focus on failure. His name is Anand Sinha, and we wanted to acknowledge this at the end in particular because he's written about, there's starting to be more popular this thing called a fail fest, essentially a celebration of failures. We're all looking to do this kind of a thing more, but we need to do it well. So we're learning, this is a baby step for us at FP 2020. We're hosting this focused on failures and mistakes. We've done it at some of our workshops. If those of you are interested in doing these kinds of conversations in your own countries or in your own communities, we'd be love to hear from you, and we can learn together about how to create a culture of understanding mistakes and failures. So please do reach out to us. I can follow up from this webinar, but I can also put my email in the chat box for those who are interested. Final moments?
And thank you, Emily, for doing this so well and bringing us together. To you, to Kate, to Sarah, and to the FP 2020 and the Knowledge Success team.
Excellent. Thank you.
Thank you very much. It was really nice to have this conversation with you all.
Excellent.
Thank you all.
Stay well, everyone.
Thank you. Bye, everyone.
Thank you.